What if the progressive morning stiffness, the pervasive cognitive fog, and the erratic blood glucose levels that you might be accepting as just an inevitable part of aging over 60 are, well, actually a consequence of fundamentally mismanaging a daily habit?
That is the exact clinical question we have to confront today. Welcome to this deep dive into the source material. We are going to examine a highly specific, very targeted pharmacological protocol.
Right. And it is a protocol that leverages basic, accessible ingredients to achieve some really profound systemic effects.
Precisely. We are looking at the administration of coffee, but not as a simple stimulant. We need to view it as a primary delivery vehicle for polyphenols, specifically when it is strictly combined with the botanical compounds found in whole cloves.
The urgency of this analysis really stems from the demographic it targets. I
Yeah.
mean, if you are a patient over 60, managing daily physical decline often results in polypharmacy. You end up layering prescription upon prescription.
Yes, and yet the material we are reviewing presents a very compelling biochemical rationale for an intervention that costs pennies a day, but that is provided the extraction chemistry is handled with absolute precision.
Exactly. Our objective today is to rigorously evaluate the physiological pathways this protocol claims to alter. So let us first establish the baseline pathology of the target demographic.
Right. The literature focuses heavily on what it terms the morning miseries. That phrase accurately encapsulates a specific constellation of clinical presentations.
And we are talking about patients who wake up with cognitive sluggishness that persists well into the late morning, right?
Yes, cognitive sluggishness, postprandial bloating, and distinct dysregulation in their glycemic control. They often experience reactive hypoglycemia.
And there's also that idiopathic articular pain, that quiet, persistent aching in the major joints, like the knees.
Correct. Furthermore, they report unrefreshing sleep. They're waking up fatigued despite achieving what should be an adequate 8-hour duration.
These symptoms are almost universally dismissed by patients as the standard pathology of aging. I mean, you treat the localized pain, perhaps with a non-steroidal anti-inflammatory drug.
And then you attempt to treat the fatigue with a stimulant. The tragedy highlighted in our underlying material is that 99% of the population completely misunderstands the chemical profile of that stimulant.
They view coffee strictly as a caffeine delivery system, right? They just perceive it as a binary biological switch to force the central nervous system from a state of rest into a state of alertness.
That reductionist view obscures the true nature of the substance. Unadulterated coffee is actually one of the most robust concentrated sources of polyphenolic compounds available in the standard Western diet.
The primary active compound being chlorogenic acid.
Exactly. And when we analyze chlorogenic acid biochemically, its function extends far beyond neurostimulation. It is a highly potent antioxidant.
So its physiological mandate, once it enters the bloodstream, is essentially the neutralization of reactive oxygen species.
Precisely. It exerts a protective effect on hepatocytes in the liver, assists in the stabilization of glucose metabolism, and critically, it actively suppresses the transcription of pro-inflammatory cytokines.
If we internalize that pharmacological profile, I mean, we are forced to completely reframe our approach to administration. We are no longer discussing a morning beverage.
No, we are discussing the ingestion of a complex phytochemical supplement. If you were prescribed a delicate, heat-sensitive medication, you would adhere strictly to the dosing and administration guidelines.
Right. Yet with coffee, the general population routinely destroys the active compounds through improper preparation, or they add substances that completely neutralize the bioavailability of the chlorogenic acid.
It is a critical failure in administration. To use an analogy that accurately reflects the magnitude of this error, it is like utilizing a highly advanced, multi-million-dollar piece of radiological equipment merely to light up a dark room.
That is a stark way to put it. You are extracting the superficial benefit, the caffeine, while entirely ignoring the sophisticated therapeutic mechanism.
Exactly. You ignore the chlorogenic acid that is fundamentally designed to address the exact systemic oxidative stress that is causing the joint pain and cognitive fatigue in the first place.
And the stakes of this systemic oxidative stress are physically manifesting in these patients every single morning. I mean, we are talking about individuals waking up with peripheral edema so severe they cannot put on their rings.
Or they experience such acute morning stiffness that just bearing weight on their knees causes vocalized pain.
Now, the source material argues that while chlorogenic acid is a potent intervention for these issues, it is biologically incomplete on its own.
Correct. It requires a complementary phytochemical partner to achieve its maximum clinical efficacy. This introduces the second variable in the protocol.
The botanical compound derived from the clove.
Yes. The specific chemical isolate of interest here is eugenol. The literature identifies the clove as the most concentrated natural source of eugenol currently known.
The literature goes even further than merely identifying it, though. It presents a stark pharmacological comparison, noting that in specific controlled observations, the anti-inflammatory action of eugenol has demonstrated an efficacy that surpasses that of ibuprofen.
That is an extraordinary assertion regarding a common culinary spice, yes.
I want to drill down into the mechanics of that claim, because ibuprofen operates by inhibiting the cyclooxygenase enzymes, COX1 and COX2, which produce prostaglandins that promote inflammation. Is eugenol operating on that exact same pathway?
Eugenol does indeed exhibit inhibitory action on the COX2 pathway, but its pharmacological profile is broader. It also inhibits lipoxygenase enzymes.
And those are responsible for producing leukotrienes, right?
Yeah.
Other major class of inflammatory mediators.
Exactly. So it is suppressing the inflammatory cascade at multiple upstream junctures. But the core thesis of the material we are reviewing is not simply that eugenol is a powerful anti-inflammatory in isolation.
The clinical focus is really on the concept of food synergy when eugenol is co-administered with chlorogenic acid.
Precisely. The material insists that combining these two specific compounds creates a biological impact that is exponentially greater than the sum of its parts. It is not an additive effect, it is a multiplier.
The eugenol is cited for its ability to act as a smooth muscle relaxant, an acute anti-inflammatory, and a potent sensitizer of insulin receptors.
And if we consider the economic disparity here, a single whole clove costs a fraction of a cent. Yet it contains a phytochemical profile capable of rivaling synthesized pharmaceuticals.
The disparity between cost and clinical value is striking. I mean, in modern allopathic medicine, we rely so heavily on isolating a single active molecule to target a single biological receptor.
However, botanical pharmacology often relies on the co-administration of compounds that work in tandem. One compound may neutralize an inhibitory enzyme, which then allows the second compound to achieve higher plasma concentrations.
We are likely overlooking numerous, highly effective synergistic interventions simply because we have abandoned the traditional administration of these complex botanicals.
We abandon them in favor of isolated synthetics, yes. Let us mathematically deconstruct this synergistic multiplier.
Right. If the source material claims this combination yields an exponential clinical benefit, we really need to understand the precise interlocking mechanisms. How exactly does the administration of eugenol amplify the efficacy of chlorogenic acid and vice versa?
We must analyze the complementary pathways they stimulate. Chlorogenic acid aggressively targets circulating free radicals, lowering the overall burden of oxidative stress.
While simultaneously, the eugenol is downregulating the enzymatic production of new inflammatory mediators.
Exactly. You have one compound cleaning up the existing systemic damage, and the second compound halting the production of further damage.
Furthermore, by improving the sensitivity of the insulin receptors, eugenol fundamentally alters the patient's metabolic state.
It creates an optimized cellular environment that allows the chlorogenic acid to process glucose more efficiently. They clear the physiological roadblocks for one another.
That provides a very clear mechanism for the systemic changes. They are executing distinct parallel tasks that compound to stabilize the entire metabolic network.
Having established the biochemical rationale for co-administration, we must look at the specific physiological timeline detailed in the source material.
The text claims observable acute alterations in patient biology beginning almost immediately upon ingestion. Let us analyze the 15-minute clinical marker.
At 15 minutes post-ingestion, the literature notes a phenomenon it describes as, quote, clarity without chaos.
This refers to the immediate alteration of the central nervous system's response to caffeine, because caffeine acts as a vasoconstrictor, right?
Yes, it triggers a mild sympathetic nervous system response, an adrenaline release that often manifests physically as chest tightness, tachycardia, or peripheral tremors commonly referred to as the jitters.
Yet the eugenol intervenes directly in that vasomotor response. The material notes that eugenol actively relaxes smooth muscle tissue,
which directly includes the endothelial lining of the vascular system.
My question is regarding the competitive nature of these actions. If caffeine is signaling the blood vessels to constrict, and eugenol is signaling them to dilate, why do they not simply cancel each other out, leaving the patient fatigued?
Because they are operating on completely different systemic levels. The caffeine successfully crosses the blood-brain barrier.
So it is successfully antagonizing adenosine receptors in the brain to maintain cognitive arousal and alertness.
Correct. However, in the peripheral vascular system, the eugenol acts as a localized vasodilator. It serves as a biological countermeasure.
It is physically preventing the smooth muscle of the blood vessels from constricting in response to the systemic adrenaline.
Exactly. The result is that the patient retains the targeted cognitive stimulation from the caffeine, but the somatic anxiety response, the physical panic, is entirely blocked by the eugenol.
The clinical implications for the patient's psychiatric baseline are quite significant. Initiating the diurnal cycle with sharp cognitive focus, completely devoid of the physical markers of anxiety, establishes an entirely different neurochemical state for the rest of the day.
But the physiological timeline progresses rapidly. At the 24-hour mark, the primary site of action transitions to the gastrointestinal tract.
The synergy within the enteric nervous system is highly documented here. The source material highlights the robust carminative properties of the clove.
In gastroenterology, a carminative agent is one that either prevents the formation of gas in the alimentary canal or facilitates the expulsion of existing gas.
Thereby rapidly reducing abdominal distension and postprandial bloating. And we must also factor in the well-documented effect of coffee on colonic motility.
Right. Coffee acts as a rapid stimulant for peristalsis, the involuntary muscle contractions that move contents through the digestive tract.
Exactly. The physiological result is a dual action mechanism. The coffee provides the necessary motor stimulation to propel waste, while the eugenol simultaneously acts as an antispasmodic.
It soothes the intestinal lining and neutralizes trapped gas. The clinical outcome described in the text is a profound evacuation of the digestive system,
resulting in an acute sensation of physical lightness that patients frequently report they've been missing for decades. It is a precisely calibrated push-and-soothe mechanism acting on the bowel.
Advancing the timeline to the 72-hour mark, the clinical data focuses entirely on endocrinology, specifically the stabilization of blood glucose levels.
This is perhaps the most critical metabolic intervention of the entire protocol. We observe a two-pronged manipulation of glucose pharmacokinetics.
First, the chlorogenic acid from the coffee acts within the intestinal lumen. It inhibits specific enzymes, such as alpha-glucosidase.
And those are responsible for breaking down complex carbohydrates. So by inhibiting these enzymes, the chlorogenic acid physically slows the absorption of glucose into the bloodstream.
The glucose curve flattens. The surge is prevented directly at the site of absorption.
Concurrently, the eugenol is acting at the cellular level to optimize the reception of whatever glucose does enter the blood. It sensitizes the insulin receptors.
Correct. The cells become highly responsive to the presence of insulin. Therefore, the pancreas is not required to secrete massive compensatory spikes of insulin to force glucose into resistant cells.
You have a slower, controlled release of glucose into the blood, met by highly efficient receptive cells ready to utilize it for energy.
This directly addresses the pathology of the reactive hypoglycemic crashes that dominate these patients' lives.
Those violent physiological swings. Consuming a high glycemic meal, experiencing a rapid surge in blood sugar, followed by a massive insulin dump that plummets the blood sugar and triggers ravenous hunger an hour later.
That entire cycle is fundamentally arrested. The literature states this entire stabilization occurs within a 3-day window.
It breaks the cycle of metabolic panic. The patient's energy levels transition from erratic and dependent on constant caloric intake to stable and sustained.
While the acute timeline is clinically impressive, the true therapeutic value requires sustained administration over weeks and months. We must now evaluate the long-term physiological timeline.
At the 7-day mark, the literature points to a systemic shift in the patient's inflammatory cascade. The material notes a quiet but highly significant reduction in systemic inflammation.
The clinical markers are observable here. A marked decrease in morning articular pain, the reduction of chronic peripheral edema, such as the swelling in the digits, and a measurable shortening in the duration of morning stiffness.
The source material is adamant that this is not a placebo effect. It claims that this reduction in inflammation is entirely quantifiable via standard hematology panels after just 1 week.
Yes, it is a bold claim.
From a clinical pathology standpoint, is the daily administration of this eugenol and chlorogenic acid complex genuinely potent enough to force a downward trend in systemic blood markers, such as C-reactive protein, in merely 7 days?
Given the multi-target mechanism we discussed earlier, it is highly plausible. C-reactive protein, or CRP, is an acute phase reactant.
It is synthesized by the liver in response to macrophage and T-cell secretion of specific cytokines. Right.
Precisely. If you introduce a daily, highly bioavailable dose of a COX-2 and lipoxygenase inhibitor like eugenol, Alongside the radical scavenging properties of chlorogenic acid, you are aggressively suppressing the upstream triggers for cytokine release.
So with a daily compounding effect, the liver simply receives fewer signals to produce CRP.
Over a continuous 7-day cycle, that suppression will absolutely reflect as a downward trend in a comprehensive metabolic panel.
The insidious nature of chronic inflammation is that patients normalize the dysfunction. I mean, they assume the grinding in their knees or the inability to close their hands in the morning is a mandatory toll exacted by age.
They do not realize they are suffering from an active, persistent inflammatory fire until a protocol like this extinguishes it.
And the absence of pain becomes sudden and shocking. Moving forward to the 30-day clinical marker, the focus shifts entirely to hepatic function.
The liver acts as the primary biochemical filtration system. The literature correctly identifies that the regular consumption of polyphenols, particularly from coffee, is clinically correlated with a reduction in hepatic steatosis.
That is fatty liver disease, and a decrease in hepatic fibrosis.
However, the introduction of eugenol amplifies this hepatic protection by directly mitigating oxidative stress within the hepatocytes themselves.
If the oxidative stress within the liver cells is reduced, we would anticipate a corresponding drop in elevated liver enzymes, such as ALT and AST, which leak into the blood when liver cells are damaged.
Yes. But the literature also highlights an external dermatological side effect resulting from this internal hepatic optimization.
The text notes that patients experience significantly clearer skin, often receiving external validation that they appear chronologically younger. What is the precise physiological link between hepatic filtration and dermatological clarity?
The integumentary system, the skin, operates as a secondary or backup organ of elimination. When the hepatic pathways are congested or overburdened by a high toxic load, the liver cannot efficiently filter and excrete metabolic waste through the biliary system.
Consequently, these toxins accumulate in the systemic circulation.
Right. The body then attempts to excrete these irritants through the skin via sweat and sebum. This chronic dermal excretion presents clinically as cellular dullness, persistent blemishes, and inflammatory dermatosis.
And the accelerated degradation of collagen, which is what causes premature aging. Therefore, by optimizing the primary filtration mechanism in the liver with a specific protocol, the liver handles the toxic burden efficiently.
The skin is no longer conscripted as an emergency exit for metabolic waste. The resulting clarity and the younger appearance are not cosmetic illusions.
They are direct visual evidence of lowered systemic toxicity.
Precisely. The external presentation is merely a reflection of the internal biochemical efficiency. Finally, as we reach the 90-day marker, the literature describes a comprehensive metabolic reset.
This reset includes notable weight loss. However, it is vital to emphasize that the material does not frame this as an anorectic weight loss drug.
No, not at all. The reduction in adipose tissue is described as a downstream consequence of repairing the insulin sensitivity combined with the inherent thermogenic properties of the coffee.
We need to explain how thermogenesis functions on a cellular level and why low insulin is a strict prerequisite for this weight loss.
Thermogenesis is the biological process of heat production, which inherently requires the expenditure of energy or calories. Coffee stimulates the central nervous system, which in turn marginally increases the basal metabolic rate.
So the body burns more calories at rest simply to maintain homeostasis.
However, thermogenesis cannot efficiently access stored adipose tissue, body fat, if insulin levels are chronically elevated. Insulin is a profoundly anabolic hormone.
Its primary directive is energy storage. When insulin is high, the biochemical pathways for lipolysis or fat burning are completely locked.
Exactly. Because the eugenol has spent the last 90 days sensitizing the receptors, the pancreas is no longer flooding the blood with insulin.
The insulin levels remain low and stable. The chemical locks on the fat cells are removed, allowing the thermogenic engine fueled by the coffee to finally access and burn the stored adipose tissue for energy.
That is the precise mechanism. The weight loss is not a trick of severe caloric restriction. It is the natural byproduct of a repaired endocrine system functioning optimally alongside a mild metabolic stimulant.
We have detailed an intervention that regulates cognitive function, stabilizes glycemic spikes, severely depresses systemic inflammation, cleanses the hepatic pathways, and initiates lipolysis.
From a clinical perspective, it appears flawless. However, this is the exact juncture where we must issue the most severe warning of this analysis.
The source material outlines a glaring, critical caveat regarding administration. Sound pharmacological theory is completely useless if the active compound is neutralized in the laboratory.
Or, in this case, the kitchen. The efficacy of botanical medicine is entirely dependent on the precision of its extraction.
The literature asserts that up to 90% of patients attempting this protocol will record zero clinical benefit because they commit fundamental errors in the preparation chemistry.
Let us detail the exact administration protocol, referred to in the literature as the right method. This requires the creation of a decoction.
Step 1 mandates the selection of 3 whole dried cloves. It explicitly forbids the use of pre-ground or powdered cloves. Why is that distinction critical?
Ground spices possess an exponentially larger surface area exposed to oxygen. The volatile oils within the clove, specifically the eugenol, will rapidly oxidize and degrade when exposed to the air.
So by utilizing the whole intact bud, the dense woody matrix of the clove acts as a physical vault.
Exactly. It preserves the structural integrity of the eugenol until the exact moment of extraction.
Step 2 dictates placing the 3 whole cloves into exactly 10 ounces of water. The water is brought to a boil, but the heat must be immediately reduced to a slow simmer.
And this simmer must be maintained for exactly 5 minutes, not 4, and crucially, not 6.
Step 3 involves straining the liquid to remove the physical cloves. Step 4 requires using this specific eugenol-infused water to brew the coffee, regardless of the mechanical brewing method preferred by the patient.
And step 5 dictates slow consumption, strictly on an empty stomach, immediately upon waking.
The thermal dynamics of that 5-minute simmer are the most critical variable in the entire protocol, aren't they?
They absolutely are. Eugenol is locked deep within a highly resilient botanical structure. Cold or warm water simply cannot penetrate it.
It requires sustained, elevated thermal energy to break the cellular walls of the clove and release the eugenol into the solvent, which is the water.
However, eugenol is a highly fragile, volatile organic compound. It is severely heat sensitive.
If the patient aggressively boils the water or allows the simmer to extend beyond that narrow 5 to 7 minute window, what occurs on a molecular level?
Thermal degradation. The excess kinetic energy fundamentally breaks the molecular bonds of the eugenol. It denatures the compound.
So the patient successfully extracts the eugenol from the clove, but instantly destroys it in the water.
Correct. They are left with a liquid that smells faintly of spice, but possesses absolute zero pharmacological value.
It is a chemical tightrope. You require exactly enough thermal energy to breach the botanical vault, but if you apply too much heat, you incinerate the contents.
Now, the material does provide a secondary, quick method for patients who cannot dedicate 5 minutes to a decoction.
The protocol dictates taking a single whole clove, violently crushing it flat with a heavy instrument to physically shatter it, dropping the shattered fragments directly into a freshly brewed cup of black coffee, and allowing it to steep for 3 minutes prior to ingestion.
The clinical literature concedes this method only yields approximately 60 to 70% of the potential bioavailability.
By physically crushing the clove, you substitute mechanical disruption for thermal disruption.
Yes. You physically break open the vault, allowing the hot coffee to act as the solvent and extract the exposed eugenol. But without the sustained, controlled heat of a proper decoction, the extraction is inefficient and incomplete.
A 70% yield is still clinically relevant. However, a 0% yield is guaranteed if the patient commits one of the 3 fatal errors outlined in the text.
Mistake number 1 is the most common intuitive error: taking a whole structurally intact clove and simply dropping it into a mug of hot coffee.
As we've established, the woody matrix of the clove is virtually impenetrable without sustained heat or mechanical destruction.
And the temperature of poured coffee in a mug drops exponentially by the minute. It lacks the thermal mass to breach the clove.
So the eugenol remains permanently locked inside, and the patient consumes nothing more than plain coffee. Mistake number 2, which we have covered, is the assumption that more is better.
Boiling the cloves for 20 minutes in an attempt to create a hyperconcentrated dose results only in the complete thermal eradication of the eugenol.
But mistake number 3 is the most severe and widespread error. It is the addition of dairy, milk or cream, and sugar to the final preparation.
The source states unequivocally that the introduction of dairy neutralizes 50 to 70% of the polyphenol bioavailability.
This is a matter of profound biochemical interference. The literature explicitly isolates casein, the primary protein structure found in mammalian dairy.
Casein molecules possess a remarkably high chemical affinity for polyphenolic compounds like chlorogenic acid.
When milk is introduced into the coffee, The casein proteins rapidly seek out and physically bind to the chlorogenic acid molecules. They initiate a process of complexation.
Correct. They lock together, forming a massive, highly stable molecular complex. When the patient ingests this mixture, the complex enters the gastrointestinal tract.
However, this new casein polyphenol structure is physically too large to pass through the intestinal wall, right?
Yes, and the digestive enzymes cannot break the highly stable bonds. The body cannot absorb it.
The polyphenols remain trapped within the casein until they are excreted as waste. The active pharmaceutical ingredient is rendered entirely biounavailable.
By adding milk, the patient is essentially applying a chemical straitjacket to the exact compounds they are attempting to utilize. The chlorogenic acid is present in the gut, but it is chemically paralyzed.
Furthermore, the addition of sugar completely invalidates the entire metabolic objective. The protocol is designed to sensitize insulin receptors and flatten the glucose curve.
Introducing liquid sucrose directly into the gastrointestinal tract forces a massive immediate insulin spike.
Which fundamentally overrides and cancels the precise endocrinological work that eugenol was attempting to perform.
It is the clinical definition of counterindication. The patient is intentionally ingesting the precise metabolic toxin the protocol was formulated to eliminate.
This analysis casts a harsh light on modern consumption habits. The multi-billion-dollar coffee industry, heavily reliant on dairy and sugar syrups, has systematically sterilized what should be the most potent source of antioxidants in the human diet.
The literature accurately describes a standard commercial latte not as a coffee beverage, but as a dessert that smells like coffee.
It is a massive caloric and glycemic insult, masquerading as morning energy. It provides absolutely zero therapeutic benefit while actively contributing to the systemic inflammation we discussed earlier.
However, for patients who suffer from severe aversions to the taste of black coffee, the material does provide clinically approved alternatives that do not trigger complexation or insulin spikes.
The patient may emulsify a small amount of pure coconut oil into the beverage or add ground cinnamon. Neither of these contains casein, and therefore they do not trap the polyphenols.
From an endocrinological perspective, the addition of cinnamon is highly advantageous, as it possesses its own independent mechanisms for augmenting insulin sensitivity, further compounding the benefits of the eugenol.
Before any clinician recommends this protocol or any patient initiates it, we must formally address the stringent medical contraindications detailed in the final section of the literature.
We have repeatedly noted the potency of eugenol. That potency mandates strict clinical oversight, particularly regarding pharmacokinetics and drug interactions.
The material issues a severe, explicit warning regarding the co-administration of this protocol with prescription anticoagulant or antiplatelet medications. This specifically includes drugs such as warfarin, clopidogrel, or even high-dose daily aspirin regimens.
We must detail the exact mechanism of this interaction. Why is eugenol contraindicated for these specific patients?
Eugenol possesses documented inherent antithrombotic properties. It naturally inhibits platelet aggregation, effectively altering the viscosity of the blood and increasing bleeding time.
When a patient is prescribed a pharmaceutical blood thinner, the dosage is meticulously titrated to achieve a specific coagulation baseline.
If the patient introduces a potent, secondary natural anticoagulant like eugenol on a daily basis, the compounding effect can dangerously suppress the body's ability to clot.
The clinical risk is severe. The patient risks spontaneous hemorrhaging, severe bruising, or uncontrollable bleeding in the event of minor trauma. It is an absolute contraindication.
Any patient currently managing cardiovascular risks with anticoagulants must be explicitly instructed to avoid this protocol without direct supervision from their hematologist or primary care physician.
The secondary contraindication concerns the structural integrity of the gastrointestinal tract. The source states that patients with active gastritis, peptic ulcer disease, or severe gastroesophageal reflux disease must avoid this intervention.
It is vital to clarify the literature's position on this. The eugenol is not the offending agent. The clove is not exacerbating the damage.
The literature is exceptionally clear on this point. It states, quote, "Coffee itself may not be for you. Clove won't fix that," end quote. It is the delivery vehicle, the coffee, that is the severe irritant.
Coffee is inherently acidic, typically possessing a pH around 5.0. Furthermore, the compounds within coffee actively stimulate the parietal cells in the stomach lining to secrete additional hydrochloric acid.
If a patient presents with an active physical lesion in the gastric mucosa, such as a peptic ulcer or widespread tissue inflammation from gastritis, introducing a highly acidic fluid that further stimulates endogenous acid production will cause severe acute pain.
And it will severely delay mucosal healing. This serves as a critical boundary for the concept of food synergy.
The eugenol possesses profound anti-inflammatory properties, but it is not a miraculous biological sealant. It cannot instantaneously repair a bleeding gastric ulcer, while the acidic nature of the coffee simultaneously attacks the open wound.
Clinicians and patients must respect the structural realities of the body. If the tissue is mechanically compromised, the protocol is contraindicated. Systemic optimization cannot override acute structural trauma.
The delivery system must be appropriate for the patient's current anatomical reality.
This concludes our deep clinical analysis of the source material. We have systematically deconstructed what is often dismissed as a trivial morning routine, revealing a highly sophisticated pharmacological intervention.
We observed how the standard transactional use of coffee as a mere caffeine stimulant ignores the profound therapeutic potential of chlorogenic acid.
We analyzed the precise mechanisms by which the introduction of eugenol from whole cloves acts as a synergistic multiplier.
We trace the physiological timeline from the acute 15-minute vasomotor modulation that eliminates the physical anxiety of caffeine through the 72-hour stabilization of the endocrine system's glucose response.
We tracked the long-term systemic downregulation of pro-inflammatory cytokines over 7 days and the subsequent hepatic optimization and metabolic reset over 90 days.
We also detailed the strict chemical parameters required for extraction, the 5-minute decoction, and the absolute necessity of avoiding casein and sucrose to prevent the complete neutralization of the active compounds.
The clinical potential demonstrated in this analysis is vast, provided the contraindications regarding anticoagulants and gastric lesions are strictly respected. The literature issues a final, pragmatic directive to you, the reader. None of this works unless you actually do it. Start tomorrow.
It is a call for clinical application. Furthermore, it suggests that disseminating this specific extraction protocol to the senior demographic, those over 60 currently suffering from the morning miseries, may represent the most accessible, high-impact medical intervention available outside of a clinical setting.
As we conclude this panel, the data forces us to confront a significant vulnerability in modern pharmacology. We have spent this time documenting the profound systemic alterations achievable through the precise combination of a common bean and a 10-cent spice.
We must ask ourselves, as clinicians and researchers, what other potent, multi-target botanical therapies have we systematically ignored or discarded in our pursuit of synthetic single-molecule interventions? Have we unintentionally compromised patient outcomes simply because we lost the historical recipes for these synergistic pairings?
It is a question that demands further clinical investigation. The complexity of human biochemistry often requires equally complex synergistic solutions. We must remain open to identifying the medicine hidden in plain sight.